Perfect. Hi, everyone. Welcome to the treatment advancements updates in TGCT. During this webinar, all participants will have their mics and videos muted. There will be a question and answer session at the end where Dr. Dale Shepard will answer questions submitted through the chat feature. We will allow participants to come off mic and ask their questions at that point. At any point, you can also message me directly if you have any questions, comments, or concerns. My name is Sydney Stern. I'm the Senior Director of TGCT Programs at TGCT Support. I will be your moderator for today. We would like to thank our sponsors, EMD Serono and Decipher Pharmaceuticals. And thank you to all of you for spending your evening, morning, wherever you are with us. Now, I would like to introduce our presenter, Dr. Dale Shepard. Dr. Shepard received a PhD in pharmacology in 1995 from OSU. I forgot what team that is, but go Buckeyes, maybe? With an emphasis on drug metabolism and pharmacokinetics. He completed his postdoctoral fellowship from University of Chicago in a multidisciplinary NIH-sponsored clinical pharmacology fellowship. He also, upon the completion of his postdoc, he was like, one doctorate isn't enough. He is also going to go get an MD from Ohio State University College of Medicine. And then he completed both his internal medicine residency in hematology and medical oncology fellowship at Cleveland Clinic. He has a vast history within the Ohio area, and in 2009, Dr. Shepard joined the Department of Hematology and Medical Oncology as the director of Tsing Cancer Institute Phase 1 programs, where he developed so many drugs that we know now today, particularly for diseases where there were few standard options available. And he is now the director of Global Oncology Partnerships and the co-chair of the sarcoma program at Cleveland Clinic. He's renowned, well known for both access and helping patients find answers as well as treatment options, and is a frequent referral to surrounding states and international patients. Hopefully, I did you justice, Dr. Shepard.
Oh my
Uh,
God, the pressure.
Please feel free to take it away and start.
All right. Oh my gosh, thanks for the incredibly kind introduction there. We are going to talk about TGCT today. We're going to talk about advancements, what's new, what's on the horizon. As we start disclosures, I give some educational talks. Advisory boards have sponsored research, so have that to share. A big thank you to Dr. Sydney Stern. She does such an amazing job for everyone related to TGCT and education, and she very graciously let me borrow a few slides for the presentation today. And she's been generous enough to let me do this presentation and a couple of podcasts. Big props to the good Dr. Stern. So we're going to talk about background of TGCT, talk about current therapies, talk about new therapies and some experimental approaches, and then what are the unanswered questions. And then I want to go through this information. I realize there's people that have a variety of sort of background knowledge perhaps in this area. So kind of cover things a little broadly, but also a little quickly, because not only unanswered questions sort of within the field, but I want to allow time for your unanswered questions as well. So I'm going to kind of balance a presentation with some question and answers. With that, what exactly is tenosynovial giant cell tumor? Again, I want to make sure we're all kind of on the same page. This is not a cancer. It is a rare disease. It affects joints, synovium, the bursa, the tendon sheath. There are two types of TGCT that are sort of radiographically distinct. There's a diffuse form and a localized form. Localized form is entirely within the joint space. The diffuse form is outside of the joint space. And it has important implications in that we're going to talk about a lot of systemic therapies, ways to manage this disease. But in many cases, localized disease can be treated surgically, low recurrence risks. We're going to focus primarily on diffuse disease. One thing that comes up sometimes, radiographically, you see these abnormalities within joint spaces. this sort of white area within the joint as we look from the side or from the front. You see these abnormalities, and even in a large institution like Cleveland Clinic here, there's always this question about, well, it's the right scenario. It looks like a TGCT, but it looks like a TGCT. Should we biopsy? Could we just go ahead and treat this? We just had one of these within the last month, actually. In fact, this one. And everyone was sort of the radiology guys, the surgery guys, like, well, come on, it looks like TGCT. But as we push for a biopsy. Stay strong, medonc, folks. Biopsy before treating, and it was a fibroma. It wasn't a TGCT at all. So, just sort of as a backdrop, things can look like something, but they aren't necessarily, and it's an important thing to consider. When we think about the mechanism for TGCT and TGCT growth, there is a translocation that leads to the production of colony stimulating factor, or CSF. And there's an expression, a portion of the cells. We'll see a cartoon about that here in the next slide. And it mediates proliferation, differentiation of macrophages, immune cells that then enter the joint space. If you were to see that previous picture where you had a mass, only a portion of that is tumor cell. And then there's a lot of inflammatory cells that are associated with that particular tumor. So CSF is expressed by some cells. The expression of the CSF1 receptor is in the majority of the cells. And this is kind of a cartoon that shows that. We have this sort of cluster of cells. It's a combination of tumor cells and tumor-associated macrophages, or immune cells that are responding to the tumor cells. So the tumor cells are what have the translocation that lead to overexpression of CSF1. That's these little green molecules that are floating through. That CSF1 can bind to the CSF1 receptors. Those receptors are both on the tumor cells themselves and on the macrophages, and that can stimulate growth and then further propagation of tumor. The treatments that we have, and we'll look at some other variations of this figure here in a little while. The primary treatments that we look at are small molecule therapies that interact with the CSF1 receptor, and they stop signals from causing cells to grow. They can control cell growth. They can control cell activity. They're small molecules that get into the cell and work at this receptor level. There's also been work in the past, and there's upcoming work on looking at antibodies that don't go inside the cell, but they work directly on the outside portion of the cells. And we'll talk about those as we go along here. One of the problems with TGCT is who exactly sees this disease and when. This causes some significant delays in treatment, delays in diagnosis, sort of confusion with patients about what they actually have and how to manage it. Patients get in sort of this loop oftentimes with they'll have pain, they'll have stiffness of an abnormality in a joint. They'll see their primary care. They get sent to rheumatology. They'll see orthopedic surgeons. They may first see a sports medicine physician. Ultimately, that diagnosis is made. There could be treatment that's recommended. Oftentimes, they get arthroscopic surgery procedures, as an example. And if it's localized disease, that might mean that they're cured of their TGCT and they might not have a recurrence. Even in diffuse disease, they might have a complete resection of that tumor and they could be cured. But oftentimes there's a recurrence and they kind of get dumped back into that loop of seeing a number of people to try to manage their disease. When their disease is no longer resectable, there's some complications in terms of the management, then they're oftentimes seen by orthopedic oncologists. They may do further, more extensive surgeries. They may actually and oftentimes we'll refer and get involved a sarcoma oncologist, and we're the ones that do the systemic therapies. And we'll talk about those systemic therapies. So the fragmentation of care is real. Patients with TGCT, they usually start out early on. They're seeing orthopedics primarily and orthopedic specialties, but that they may be involved with sort of that diagnosis and initial treatment for over a year until a diagnosis is ultimately made. And then majority of those patients end up switching either to orthopedic oncology or medical oncology for further treatment and evaluation. And if you look at this, if you look at sort of the list of all the providers, these patients oftentimes have seen a lot of different people. And so the majority of patients have seen, as we saw in that previous slide, a whole bunch of different people that get involved in their care. So what about non-surgical options? That's when patients they have unresectable disease. In most cases, they get referred to medical oncology. Quite honestly, the definition of resectable disease seems to be changing as we get new ways to treat this disease. As we think about systemic therapies being given for patients kind of by indication for unresectable disease or disease that there would be significant morbidity if it was resected, that view of what's really morbid and what's really resectable seems to have changed over time. If we look at targets that are involved for treatment, kind of a modification of what we saw previously, the tumor cell itself has these CSF1 receptors that bind the CSF1 that's out in the circulation and can stimulate growth. There's also something called a platelet-derived growth factor receptor, or c-KIT, other tyrosine kinase. And historically, some of the treatments that we had used in the past were a drug called imatinib and nilotinib, still out there, still being used, but not as frequently. Now we have drugs, pexidartinib and vimseltinib, that work on these tyrosine kinase KIT inhibitors. They also work on both the macrophages and tumor cells through this CSF1 receptor. And so we're going to go through and kind of talk a little bit more about those specific treatments. Also, if you look at a lot of reviews, you look through the literature, you look and say there are other drugs that are listed as potentials. This lacnotuzumab is an example, AMB05X. We'll talk about those later as things that have been in development, and kind of where they are in the grand scheme of things. So just so you can kind of have a sense of what's there now for use, what's upcoming, and what could be a target in the future. I'll give you a heads up. The lacnotuzumab, the AMB05X, not necessarily good targets right now, and we'll talk about why in a little bit. Amactituzumab is going to be this, we're going to talk about later, that's something called the Tangent trial. And a drug called pimicotinib is not currently approved, but there's the Maneuver trial that we'll talk about, which is a phase 3 trial. And that's another a promising therapy. We think about treatment, we're thinking about how to treat, we think about this disease. It is really important to think about a couple of things. One would be when to treat, and the other thing is if you decide to treat, what to treat with, and what are the factors that come into play in terms of how you choose a therapy. And so some things that are important when we think about how to treat would be how symptomatic a patient is, and what's the impact of the disease on their quality of life, and also impact of the treatment on quality of life. So this is very much a disease where it's not necessarily the size of the tumor that's important, but it's really what the functional consequence of the tumor. I remember I had a patient that showed up looking to enroll in a clinical trial, required growth of tumor. It also required symptoms. Patients had to have pain or stiffness. And the patient had a tumor that was 15 centimeter in their knee. They worked in a job where they stood all day long and didn't actually qualify for the trial because they had no pain and no stiffness. And so really big tumor on pictures. It was hard to believe they didn't have any symptoms, but they didn't. And so the symptomatic part is really important. Radiographic progression, we pay attention to the images, we pay attention to the size. It can be a factor in treatment, but again, symptoms oftentimes are one of the more important parts. Potential for long-term joint complications. So as part of that mechanism of tumor recruiting macrophages and immune responses in the joint, we can find a damage to the joint as part of this disease. So there could be some degradation of bone and cartilage, and you can get damage to joints as a result of having tumor there. What we haven't figured out so far in any prospective manner, and in a way where we have a study that proves this, is that by treating the disease, we can shrink tumor, we can improve symptoms, but we don't have as good a data so far that we've impacted the joint complications or potential joint complications. So that's still work that I think is going to be important because I think it plays into things about duration of treatments. Tolerance for complexity of treatment and monitoring. There are some treatments that are a little bit more complex in terms of how they're administered, the things that have to be done in terms of when you take them, how frequently, watching diets, how often you need lab work, things like that. So that could be a consideration. Side effects themselves can vary from drug to drug and treatment to treatment. So there are some things that patient by patient, they'll have a preference on what types of side effects they might be more or less interested in having. Fertility is always a concern when we're giving any drug in medical oncology. Social support, complying with follow-up, and then what clinical trials might be available. So a number of things we have to think about. First, when to treat and what to consider when we think about treatments. We're going to go through the drugs that are approved, just again as a backdrop. If we're going to talk about new things that are out there, we need to understand what's out there now. And so pexidartinib is the first of the CSF1 drugs that was approved. If you look at the early response rates, and so these are trials, the trial was done where patients were randomized to get pexidartinib or placebo. They were treated for 25 weeks, and this is the same sort of scheme for each of the drugs we're going to talk about. Placebo versus drug, 25 weeks of treatment, looking at assessment at that 25 weeks, and then allowing crossover at that particular time. So the initial data we look at for responses at 25 weeks. I'm going to show you some longer term data for these drugs here in a little while. So the response rate, 39% by RECIST. RECIST is where you look and you measure side to side how big the tumor is. 56% response by tumor volume score. Tumor volume score is more of a research sort of construct. It's really taking into account the volume, as it says, instead of the sort of linear side-to-side measurement. These are tumors that kind of infiltrate into joints. Oftentimes difficult to know exactly how to measure from time to time. They change in size a little bit. So the tumor volume score accounts for that sometimes. Importantly, improvements in range of motion, quality of life scores. At a duration, at the initial reading, 22 months of follow-up, the median duration of response. If a person had a response, how long did that response last? Had not been reached, and I'm going to show some longer-term data in a bit. Patients who discontinue treatment may not require retreatment for a long period of time, and so we'll show some data about that as well. One concern with pexidartinib, which was that first drug, is liver toxicity. There is actually a black box warning. There's a REMS program. A REMS program is where the physician has to be educated and registered to write for the drug. The patient has to register and agree to receive the drug, there's finite periods where labs have to be collected and submitted to the pharmacy, or they will not dispense the drug. And it's because of the early trials there were some concerns about liver toxicity. Many patients have mild elevations in their liver enzymes, but specifically the concern was for liver toxicity. So as a result, there is a REMS program to try to mitigate that. That this is a drug now given twice a day with a low-fat diet. And so there, I mentioned before about sort of complexity of treatment. Twice a day, low-fat diet would be a consideration for getting this particular drug. Second drug that came out is a drug called vimseltinib. This is a result of the MOTION trial. Again, same study construct comparing to placebo. If you look at this at that 25-week mark, there were 5% rather the patients that had a complete response, partial response in 35% of patients. So overall good response rates. The duration of response again had not been reached. These are drugs where, and this is a disease where patients get on treatment, and oftentimes they are on treatment for a long period of time with good control. This, again, is not like a cancer where patients get on a drug, and then in some cases, within 3, 4, 6 months, their disease is growing again. So the duration of response to these can be very long. That, of course, brings up another important question with these drugs in general, and that is how long you treat. So we're gonna look at a little bit of data about that later, but it raises the question about when to treat, but also how long to treat. So good responses, 40% response rates. Again, if you look at things that matter to patients when they wake up in the morning, their question is, do I hurt? Can I do what I want to do? Do I have stiffness? It isn't, do I have 3 millimeter less tumor in my knee? So again, we're oftentimes starting these treatments because of symptoms. And so it's important that we have good symptom control. So the vimseltinib has been very effective in showing that. From a toxicity standpoint, these drugs are things we have to keep a close eye on. In the trial, there was a need for some dose modifications due to adverse effects. Only 6% of patients, though, discontinued treatment because of adverse events. And so, importantly, with this particular drug, we didn't see the same issue with liver toxicity. And so there's not a REMS program. You can get mild elevations of AST, ALT. There's a class effect. These drugs can cause an increase in blood CPK levels. This has to do with a direct effect on liver cells. This is not a toxicity per se, but the big strong point here is good efficacy, but without the REMS program. So this is something that as we move along and we look at newer drugs, can we improve efficacy? How many patients respond? Can we affect duration of response? Can we affect toxicity profile? Important to point out from a logistics standpoint, this is a drug that instead of giving twice a day, it is given twice a week. So again, it's an oral medication given twice a week. If we think about pros and cons, can rapidly cause improvement in symptoms, which is what we're looking for, can get long-term remissions, don't get liver toxicity. And another side effect with the pexidartinib is that there can be a lightening of skin and a lightening of hair, and we don't see that with vimseltinib. I mentioned twice weekly dosing. It is approved by the EU and here in the United States. From a toxicity standpoint, a little bit more edema, some more GI issues, and some more rash is what we see with this particular one. Pimicotinib. Pimicotinib is the third of the CSF1 drugs that has been studied. It's been studied in something called the Maneuver trial. same structure again. Again, this is a drug where the phase 3 trial has been completed. This is currently being evaluated by the FDA, but it has not yet been approved. If we look at the data, we got an overall response rate of 54% at that 24 or 25 weeks rather. If you look at overall response rates, again, by the tumor volume score, it's a little bit higher. This is something we see frequently with these drugs. That tumor volume score is the responses tend to be higher. Again, this is something that's more of a research construct. It is difficult to get a radiologist to, on a routine basis, give us a tumor volume score. And I would argue that, quite honestly, when I walk into a patient's room and I ask how they feel, and they're telling me about the improvement in their symptoms, that's probably more important than comparing whether I'm going to measure with RECIST or whether I'm going to measure with a tumor volume score. If you look at longer term follow-up, and we're going to see this with a more formal study with with pexidartinib here in a second. These drugs oftentimes don't work quickly. There are patients that will continue to get responses past that 25-week point. So if you look in the maneuver trial, if you look at longer term follow-up of over a year, instead of the 25 weeks, the response rate goes up to 76%. So significant number of patients who start drug, have tumor shrink, have improvements in symptoms, and 40% of the patients had a response by 13 weeks of treatment. So again, if we're starting treatment because of side effects, symptoms, that's important. If you look at toxicity, dose modifications, again, are something that we have to pay attention to. It's important really because if patients are able to get a drug that can be effective by doing dose modifications, dose reductions, dose interruptions, you can effectively get patients on treatment. These drugs in general tend to have toxicities that occur early in the course of treatment. These do not typically have more side effects that accumulate during the course of treatment. So about half the patients had a dose interruption, about 8% with dose reductions. Only 2% of patients, 1.6%, discontinue because of toxicities. As with vimseltinib, not related, we don't have the hair and skin hypopigmentation. We don't have the liver enzyme abnormalities or liver toxicity. We have some elevations, again, CPK. There can be some increases in AST, as an example, but these are not high grade. These are not to the point where, again, there's not the need for a REMS program. So if we think about this one in comparison, again, rapid responses, good tumor responses, so response both radiographically and symptomatically. We don't have the same liver toxicity issues we get with pexidartinib rather. No hair pigmentation. This is once daily. This is currently approved in China, not yet approved in the EU, UK, US. As with vimseltinib, some edema, GI issues, some rash. FDA is currently evaluating this, and the decision is expected by November of this year. So more to come with that one. So it's still in the potential future category because it's one that we don't yet have approval, but data looks promising and it's being evaluated. So what about future options? Where are we going? So if we think about targets to treatment, we'll show this cartoon here again. We've talked about the pexidartinib and the vimseltinib and the pimicotinib. Those work directly on the CSF1 receptor. We also talked about CSF1 itself as a potential target. And we're going to talk about an antibody, imactuzumab, that it's instead of inhibiting the receptor at the intracellular level, it's an antibody that just blocks the um, the activation of that receptor. We talked about the maneuver trial, which is the phase 3 trial of pimicotinib. We're going to talk about the tangent trial, which is the phase 3 trial for imactuzumab. The basis for this is really a relatively small phase 1 trial. So a trial that looked at a small number of patients, looked for response and looked for toxicity. And in fact, the primary goal of that early phase study was to look and see how safe it was. Tended to be pretty well tolerated, very similar from a toxicity standpoint to the CSF1 receptors. Is a little bit more issues with skin with this particular study. Again, very small number of patients. If you look at one patient each for each of these toxicities. But again, the toxicities that occur were relatively minor. There is an upcoming tangent trial. This is a trial that is not yet started, but has been planned. This is a trial that is looking at an IV infusion. So remember the drugs we've talked about so far: pexidartinib, twice a day pills with a low-fat diet; vimseltinib, which is pills, which is twice a week. We talked about pimicotinib, which was a pill that's taken once a day. This is a departure from that. This is an IV therapy. And this is, again, same study design, 25 weeks on. I'm sorry, this is not the 25 weeks. Same design, randomization of placebo and imactuzumab. Instead of saying it's for 25 weeks, what I meant to say is it's not for 25 weeks. Because one thing that is a feature of this particular drug is the thought that this would be given as an IV infusion every 2 weeks, but only given for 5 cycles. So a very finite period of time. Unlike the pills, which as I mentioned, we're not entirely sure how long to give those. In this case, it's a very fixed period of time. This study is not yet started. It's been in development. I think from a development of drug standpoint, it's important to point out that this phase 1 trial was reported back in 2015. And just last month was the publication that sort of talked about this upcoming tangent trial. So a very long period of time between initial discovery, initial investigation, and now. Another interesting approach is an intra-articular injection. So taking an antibody, again, this is the same concept of using an antibody to the CSF1 receptor and injecting that antibody directly into the joint with the tumor. And so interesting concept. Unfortunately, the study was done again about 8 to 10 years ago with only 11 patients. It was a single. It was a very small group. It wasn't randomized in any way. It was only looking to see sort of proof of principle. It was given for every 2 weeks for 6 injections. There was some response. Unfortunately, this drug does not look like it's moving forward. There was a reduction in an improvement rather in symptoms. There were some patients that had a response of the tumor itself. Again, small numbers, so it's hard to know with any certainty. But mild to moderate toxicity for the most part, things that we associate with the CSF1 receptors. But the company that developed this, it doesn't look like there's really a plan to continue with development of this. So, but again, something that's an interesting mechanism. I mention this one again because oftentimes when you look through literature, you'll find this as something that's being studied. this is kind of the data behind it, but it doesn't look like at this point it's moving forward. Lacnotuzumab is another drug that, there's a number of ways you can inhibit a receptor. So if you think about the CSF1 receptor, we've talked about the receptor, the small molecules that are intracellular that block the receptor. We've talked about antibodies that can bind to the outside part of the receptor. This is a concept of, well, what if you just sort of get an antibody and you bind the CSF1 itself, and then that way it won't be able to bind the receptor to activate it. This is a drug that was being developed by Novartis. Again, I've mentioned it here because when we think about new therapies, this sometimes gets thrown on the list of things that have been worked on in the past. The only data we have for this at this point was a single dose that was given to 5 patients with TGCT. That abstract was presented at a conference back in 2015. There wasn't a subsequent publication. There was a study that combined this drug with a chemotherapy for patients with breast cancer. There were elevations in AST and ALT. There was CK elevations, and it looks as though that sort of halted the development of this any further. So, I guess, again, looking at like the alternate ways that this can be treated, this certainly could show up again. There could be another drug that shows up looking at this mechanism. Remember the time gap with the emactuzumab. We never know if something might get resurrected, but I thought it was important to sort of throw that out there that as things that could be developed. What are treatment-related questions that remain? We've talked a little bit about this. How long will tumors respond? Are there cumulative adverse effects? How durable are the responses? And are tumors responsive to retreatment? So just really quickly, you always wonder about trials, how trials reflect reality. There's some real-world data. So I'm going to show a couple things with pexidartinib here because this is the drug that's been out longest. They went through, remember, patients have to be registered in the REMS program or they don't get drug. So that allows you to do some studies in terms of who's actually in the real world getting the drug. So this was a study looked at 288 patients who had been enrolled and getting a sense for how well they responded in terms of management of symptoms when they were on the drug. They ended up with 83 patients filling out the surveys, and they compared essentially use of physical therapy or pain medications prior to starting treatment or while they were getting treatments. And it looked like in a real world setting that there seemed to be good benefit clinically. So it's always good to see that in the real world, people that weren't within the tight guardrails of a clinical trial, that they were actually getting benefit. And if you look at the safety data, it was very, very consistent with the trial. So the things that from a side effect standpoint were kind of what we would expect otherwise. Need for dose changes and modifications and things were really pretty consistent. So always good to get confirmation from those things. What about long-term data? Again, pexidartinib has been out long enough that we can get some long-term data. We talked before with pimicotinib, 54% at 25 weeks, but then up to 76% with long-term follow-up. Looking at similar things with pexidartinib, overall response rate over time went from 37% to 55%. Interesting that the duration of response, how long patients responded, even with the longer term use, wasn't reached. And so that median, how long people are on it, this is very much something where if patients start treatment, that treatment seems to remain effective. Again, not like a cancer where you get mutations of tumors that cause changes. In fact, patients were on treatment for up to 5 years. Again, we talk about how long a patient might be on. Sometimes clinically, we might think about taking patients off sooner, But in a trial setting, patients were on for a very long time and they continued to have good response. In fact, in this group, there was only one person with progressive disease. That person actually had progression during the initial 25-week period. So this wasn't someone who sort of lost control of their tumor in long-term follow-up. Also didn't note any significant changes in the side effect profile. Again, when you think about drugs, some drugs will cause cumulative toxicity. Some drugs have more toxicity up front, which is what appeared to be the case here. So how about treatment discontinuation, retreatment? We talked about that, sort of like how long do you need to be on? What happens if you stop? There's a phase 4 trial of pexidartinib. They looked at patients who had been in any of the clinical trials. And then some of the patients that were in those clinical trials continue. There was a continuation cohort. So 21 patients just stayed on as if they were still on trial. There were another group that stopped treatment. And then in that particular group, there were 8 patients of the 11 that during the treatment period that did not have recurrence of their tumor, and only 3 of the patients, again small numbers, but of 11 people who discontinued, only 3 of them ended up needing to restart treatment. This is kind of graphically what that looks like. So patients stopped, patients entered into this sort of observation sort of period, continue with treatment, everyone continued to have control of their tumor. If you stopped, 3 of the 11 ended up with disease recurrence. If they had disease recurrence, they started drug again. And if you look among those 3 people, within 6 months, they had disease control again. And so patients could be re-challenged with pexidartinib. Again, really small numbers. This is something I think with management of disease, we need to understand a little bit more. But if a patient stopped the drug, if the disease came back, they were able to reestablish control with restarting drug. So many options. So how do you choose? So we'll look just among the things that we've talked about as our CSF1 agents. Imatinib, I didn't talk a whole lot about. This is something that was used prior to the CSF1 receptor inhibitors. There is data. The data is not as robust as with pexidartinib or vimseltinib. It is inexpensive. The response rates are lower. Again, back to what is important from a side effect standpoint, from an ease of use standpoint. If you look at pexidartinib, we have long-term data. I just showed you some data of people who've been on for very, very long periods of time. People have very long responses, but there's a REMS program, and there are patients that have been, I see patients who might want to actually get a second or third surgery instead of going on pexidartinib back when that was our option, because they were afraid of the liver toxicity. There is the twice daily dosing. This is a disease that affects a lot of younger people who don't necessarily want to take pills. And this plays into all of the dosing strategies, quite honestly. There are people who might want to say, well, twice a day, it's okay by me. Low-fat meal in that group can be frustrating to some. I had one person who stopped therapy, and the first thing they were going to do was eat French fries. So it is something that matters. So if we're looking at quality of life, it's overall quality of life. Vimseltinib, again, twice a week dosing. So, and some patients would say, well, I don't want to take anything twice a day, but if it's twice a week, I'm afraid I'm going to forget. And so, there are other people that would say, if I only have to take a pill twice a week, that's fantastic. So there's a lot of patient nuance here. Don't have the issues with skin or hair color changes. You don't have the severe toxicity requiring a REMS. We don't have long-term data about starting, stopping, again, because this has only been approved for a much shorter period of time. The next two, we don't yet have approval for pimicotinib, but daily dosing. So, sometimes people would say, well, once a day, I take it every morning. I'm good. I'll remember. We don't have the hair and skin color changes. We don't yet have approval. We'll find that out hopefully within the next couple of months. There are sort of anecdotally a little bit more edema and a little bit more uh, rash and skin changes. If things get approved, they get out into the wild, if you will, we understand a lot more about toxicities, how to manage them. Sometimes things that are issues for any of these drugs. One things that might be issues in a trial setting, um, we have sometimes they are momentarily worse when they get out in people that aren't used to giving them or giving them, and sometimes they get better because we understand how to manage them. So some of the toxicities with things like pimicotinib, we're going to have to learn about how to identify and treat if we have this as a drug that's approved. And then imactuzumab, the the dose advantage here would be that you get 5 doses and you're done. Very appealing to a lot of people. It is an IV therapy instead of an oral therapy, which could be a factor for some people. And again, this is very early in development. There's been a long gap between the early data and what we have now. So the most important things here are figuring out when a patient needs to be treated, figuring out what's right for that patient in terms of the combination of efficacy and improvement in symptoms and the decreased burden on patients in terms of the therapies themselves. So that's kind of a look at therapies we have, therapies that could be in development, letting you know about some of the things that you might see out there and where they are. And so want to be able to take some questions. So I guess we'll take questions, comments, criticism, or compliments. So we'll take any of them.
Thank you so much, Dr. Shepard. So some questions that we've already received. You had mentioned that Pexi, for example, is taken with a low-fat diet. They wanted you to clarify or provide some clarification. Is that low-fat diet when you're taking Turalio, right? It's the 11 to 14 grams of fat, but it's not the diet throughout the day, right?
Yeah, it has to do with you're exactly right. It has to do with the dosing itself. So, but again, people sometimes don't like to. I guess there's a couple things. People sometimes don't like modifying diet, particularly when they're sort of in the younger age groups. They may not want to. They're not used to taking any medication at all, and so that added burden is sometimes a little more. I got to tell you, as a provider, um, I sometimes don't know if they're actually following that, and so that's certainly the guidance. But yeah, but that would be with the drug.
Okay, thank you. And I know you're pretty much an adult oncologist, but do you have any knowledge of data related to Pexi or Vim in pediatric patients?
I'm going to plead ignorance on that one because I only see people 18 and over, and so I just don't know about that part. So
Okay, for any pediatric patients, we do have some amazing resources directly on our website if you'd like. And then please feel free to send any questions directly about peds, and I can send them to our pediatric medical oncologist and pediatric orthopedic oncologist that we work closely with as well in Ohio, actually, Tom Scharschmidt. So
there you
I'm
go.
very happy
Yeah.
to pass the information along. Um, so you showed some long-term data for pimicotinib as well as Pexi, and you can see that if patients tend to have a response or an increased response over time is what you showed. But if a patient didn't have a response or improvement at 6 months, would they drop out? And would that affect that those that with the response at 1 year are actually those that had a response already, either in symptoms or treatment?
Okay. So correct. So
Okay.
really that ends up being patients that have had continued, they've continued on drug, um, they've continued to accumulate a response, if you will, right? So, there are patients, again, if we're dosing something on It's important to separate out radiographic response to symptomatic response. And so there may well be people who very quickly had improvement in their symptoms. They had less pain, they had less stiffness, they had increased function, but they may not have reached the level of having a radiographic response. And so if that's the case, they may be continuing on drug, and then over the course of time, the radiographic response catches up, if you will. So I think
That
that's
makes
a
sense.
lot of
Yeah.
what we're seeing there.
Um, Another question was about the mechanisms between Tralio and or pexidartinib and vimseltinib. So what are the difference between those mechanisms?
So I think what we see here is that, you know, they're, anytime we look at these receptor inhibitors, um, what we're trying to do is optimize the beneficial parts of that mechanism, and we're trying to minimize what we would consider off-target mechanisms. So any of these receptors, these receptor inhibitors, oftentimes we think it hits, we know it hits the CSF1 receptor, but there could also be effects on PDGFR receptor, or the KIT receptor, or any of a number of other of the dozens of tyrosine kinase class receptors. So what we oftentimes see from first generation to second generation and on as the drugs get developed isn't necessarily an improvement in how many people have improvement in pain or how many people have a change in the size of their tumor, but we get maybe better specificity for a receptor, less effects on other receptors, and we get a cleaner side effect profile. And so oftentimes it's not necessarily the fundamental mechanisms the same. It's a tyrosine kinase inhibitor. It's a small molecule. It goes inside the cell and it blocks activation of the CSF1 receptor. But the difference between them becomes on what other receptors might become involved. And so this is something we commonly see with a lot of drugs. Subsequent lines of therapy of development, maybe even equivalent efficacy, but better toxicity.
Thank you. I think that that was a lovely explanation of the differences. I can like listen to that forever.
But I
Some,
wouldn't recommend it.
yeah, some patients had asked, have you seen immune-mediated side effects such as lupus with the injectables? Because biologics, are so different than small molecules. Have you seen the lupus-like symptoms that have been described?
Yeah, so the answer would be no, because the injectable therapy right now is we really have a pretty limited we have a limited experience at this point. That tangent trial is that antibody that's going to bind to the CSF1 receptor and kind of block the CSF1 from binding to it. Um,
Yeah, they haven't published data, correct? Like the data isn't out yet.
so all we have at this point, we have the phase 1 data that I had shown with that limited data set, and they did have some skin issues. They did have lupus, like symptoms as a toxicity, but we don't really have any larger experience. So that's going to be an important thing to determine as that tangent trial sort of rolls out.
Yeah,
Is
waiting for that readout, right?
I know we're waiting. We've been waiting. We've been just waiting to see what we find out. Uh,
Okay.
so that's going to be the important part.
Similarly, because those are injectables and because they stick around for a long time, do you know how long it takes for those kind of side effects to subside?
I think it's I don't know
Like
with
imacduzumab.
certainty like what exactly the mechanism is um in terms of what triggers it, in that if it is developing sort of, one can imagine that if you've had an exposure and you've developed the ability to create an antibody that causes it, then that antibody might be that formation, the development of that antibody might be fairly long lasting. And so it may be more than just discontinuing the drug. So I think that's what we're going to have to wait and see.
Thank you. A patient and oh, this patient, the comment will you'll see. I guess it'll make us all a little surprised. But a patient had mentioned that a biopsy is the best way to determine diagnosis, is what you had mentioned. But their ortho surgeon observed a rusty color within the synovium during surgery, and then therefore did not send it to a lab for a pathology report. Um, you can probably comment that the rusty color is not a diagnostic feature or not enough to diagnose, but what would be involved in getting a biopsy now?
Um, I could point that out and will point that out. So, I mean, if tumor, I guess if you're worried about tumor, the only way to diagnose is under a microscope. I mean, you can't tell by what it looks like. You can't tell by, well, this is clinically, where we need to be. The only way to do that is to get a piece of it and get it under the microscope. Ideally, you end up, determining that you have cells with the translocation. Um, so pathology itself, you can't just tell by the appearance of what it looked like in the coming out of the biopsy needle, what it looked like on a scan, anything like that. Um, so has to go to the lab.
Thank you. I think that the medical oncology is special in that we like data just in case. And I think all of the top um, orthopedic oncologists who are so sure have been stumped before too, where they're like, this doesn't, this looks like TGCT, it walks like TGCT, and then it's not TGCT. And so a biopsy is certainly gold standard. And so for this patient specifically, please feel free to reach out to me directly and we can make sure that we can, if there is tissue remaining, we can get you to an expert who can do a needle biopsy. And actually, hopefully they didn't throw away the tissue and then it can be maybe reassessed by a different lab or different provider that's going to be more on top of it. So,
Yeah. I mean,
um,
it's important. We don't have a lot of active trials open right now, but it becomes important not only for confirming the diagnosis and not getting potentially toxic drugs, even the drugs that are safe, or there's still toxicity. Once we start them, we don't know how long people are going to be on them. Um, and oftentimes in a trial setting, you have to have pathologically confirmed disease. So it's important to get the biopsy.
so shifting gears a little bit, how often are you treating patients who are considered asymptomatic with these? And if you are, do you have a preference?
I really do try to limit exposure of people that don't have symptoms, limit their exposure to things that could be harmful. Um, I in as I say this, I want to make sure that nobody thinks I'm minimizing this disease at all in any way. But it is important to realize that this is not what I treat otherwise, which is cancer. If I find a cancer, as long as there is visible tumor there, there's risk for rapid growth, there's risk for spread, there's risk for significant harm by leaving tumor there. Okay. In this setting, this is not a disease that is going to metastasize. If there is some remaining tumor, it is not going to go to bones and liver and lungs. And and again, I want to make absolutely certain nobody thinks I'm minimizing here. But the reality is that as we make a treatment decision, if I have a tumor that is 3 centimeter in size and absolutely asymptomatic, um, I don't know that I necessarily am going to benefit a patient by getting it to 2.5 centimeter. They're already asymptomatic. If it's 6 centimeter and they're having pain, and I get it to 4 centimeter, do I really need to get it to 3 if they're already feeling better? So that's where that interplay between size and symptoms becomes really important. So, I mean, that's kind of it's not eliminate tumor at all costs in any visible. It's about what is the impact of the tumor on a patient.
Thank you. I think that that so holistically emphasizes, I think, the role of even what TGCT support is trying to like encourage people for education too. So I love the effort of focusing on symptoms, especially because in many of these young patients, right, you'll be on the drug forever if you only care about tissue.
Right.
So very important emphasis. Um,
I mean,
similar.
just really quickly, I think the other thing that's going to be really important, if we can answer the question about whether we're able to minimize joint damage, I think that's going to be important in terms of a factor in terms of starting drugs and even continuing drugs. If we know we can save a joint from some sort of erosive damage, then maybe you do start treatment sooner. But right now, I don't have that data. I don't know that by treating the tumor, I'm going to make the joint healthier, if you will.
So some more questions, and you said so for everybody that we'll run a few minutes over because Dr. Shepard is giving us more of his amazing time. You had mentioned specifically that biopsies were important. How often do you have biopsies that are inconclusive or would not find the fusion, or do you even test for the fusion in the biopsy?
I mean, in all fairness, it's there's a bit of a skew in what I see, in that most people that I see in my clinic have already had a surgery or three. And so typically I'm not normally getting the biopsy myself. I'm normally seeing someone who's already had a biopsy or a surgical procedure. So I guess I have a skewed view on biopsy proven. The example I showed earlier, that just happened to be somebody who was wanting to come in for a consult and should I see surgery? Should I get a biopsy? Should I see med onc? Should I just start treatment? And those decisions were being made, but that was a little atypical because most people are coming from um, usually an orthopedic surgeon, at least the patients that I'm seeing in my clinic.
And your pathologists, not to speak for them, but they don't test for the fusion directly, right? It's under histology alone.
Usually, yeah, usually it's histology.
Okay. So another patient had asked, do all drugs cause like skin sensitivity to the sun, or is that just Trualia or pexidartinib?
I think we see it more with the pexidartinib. Um, I have not seen it nearly to the same extent with vimseltinib. I mean, sometimes these are sort of class effects. I mean, a lot of the tyrosine kinase inhibitors as a family can cause some skin sensitivity. But I think it is a little bit more of an issue with the pexidartinib. And I don't know if it's just a direct effect or um, I have had some patients of color who really one of their major annoyances with pexidartinib is that they were becoming lighter. And so they were fine with every aspect of the drug other than they were getting lighter skin.
We've heard similar about hair, right? That the hair is either a great part of it that you get to be like Dove Cameron White, or it is totally just to changes your identity, right?
Oh yeah, I mean, and again, it's about, you have to talk to the patients and see what's important. I mean, I've had 22-year-olds that love rocking white hair, and I have, 23-year-olds who just are mortified by it. So
And
this is where
that's
you have to look at that sort of spectrum of what the possible side effects are and sort of weigh what's most important to people.
And that's because of pexidartinib targets c-Kit, right? That's so it impacts
Mhm.
the like melanocytes survival and function, right? And so
Correct.
pigment, yeah.
And again, it's that sort of, we call a drug a CSF1 receptor inhibitor, but it hits other things as well.
One of the patients in the comments said that they're not too happy about the hair color. So it says it changes everybody. Everybody has different preferences, I guess.
Yeah.
Um, so one of the questions regarding fertility, are there concerns particularly with fertility? How do you weigh that in decisions and in your recommendation of what drug to pick?
I think it's one of those things where I can't honestly say that I would be happy with anyone becoming pregnant on any of them. I mean, this is just, in general, the things that I give for, not only this disease, but any others, there's the potential that you get reproductive changes. And so I think the pregnancy part itself, the fertility part itself, that weighs more to my mind in terms of um, if you're going to start a therapy now, if a patient is having relatively mild symptoms, if they had no concern about, if they did not want to start a family, I might go ahead and start them on a treatment. If they want to start a family, I might want them to get through a pregnancy and then start treatment. Um, I don't like people going back and getting repeat surgeries, but if in fact they have only had a surgery. The surgeon says it's relatively easy to do another surgery. I might be concerned. I would be concerned that it's going to come back and I'm just kicking the can down the road. But that would enable a patient to start a family, and then maybe if there's the recurrence that I'm concerned about, there may be a different point in their life where going on a drug would be a little bit more, forgiving. So.
And there's fertility preservation, so as well. So there's a role of that. Does that also apply the same concept with male fertility or just female fertility?
Yeah, I mean, I think it's is male and female. I mean, I think the very practical consideration is that um, fertility fertility preservation is a really important concept, but I think there's two things that come up. Um, One is that particularly for patients who are oftentimes younger, they have this disease, it can be time consuming and really expensive. And the other issue, quite honestly, is that even if there are situations where there's support available for patients with a cancer that's going to be starting a chemotherapy, it's unfortunate because this isn't a cancer. Sometimes those resources aren't as readily
Yeah.
available. And so I think that creates a barrier. So oftentimes, we can talk about fertility preservation, but I think just trying to avoid treatment and working around pregnancy concerns is oftentimes the more just pragmatic way to deal with it.
Thank you. Two more questions, and I appreciate all your free time. So, have you seen vimseltinib or any of the other CSF1 inhibitors used in combination with surgery as a way to risk recurrence after the fact, and any guidance related to that use?
Yeah, I mean, I guess I'll answer that and answer it's sort of an opposite way as well. So, um, I have not used these drugs in combination with surgery either before or after. So your initial is, your initial question really was after surgery, do you use it to minimize risk of recurrence? And I do not. And I think that really if I'm going to be stay true to using a drug and putting people at risk for adverse effects and things in a setting where they're having symptoms and they need it, then it's kind of contrary to that. It's also where we quite honestly don't have data for that. Um, there are many cases in cancer where a drug might be very, very effective for metastatic disease. If you have a tumor present, but in a setting where you're giving it after surgery to minimize recurrence, it does not work at all. And so there are many, many examples of that. There are examples, bevacizumab works really well in colon cancer if you have metastatic disease, but people actually don't live as long if you give it to minimize recurrence. So I don't use it in those settings simply because we just don't have the data and I don't want to put people at risk when really my goal is to make them more asymptomatic. Um, the opposite side, I mentioned kind of in passing that sometimes I think surgeons are a little quicker to send people to us for systemic treatments because I don't know. I'm going to argue that surgeons are kind of want to get it fixed kind of folks,
Yeah.
right? And so they like when somebody comes in, they've got a bad hip, they put a new hip in, and next thing you know, the person's on their way. TGCT, they do a surgery, they take out a tumor, and guess what? The guy comes back. And so they take it out, and guess what? The guy comes back. And I think they groan a little bit when they see him on their schedule again, right? So if there are options where they can get a therapy that's going to control their tumor effectively and they're not going back to surgery, I think many of them are actually kind of happy. What I've seen is sometimes it looks like there might be differences now in what would be considered resectable or not, or morbid or not. And so people in the past might have just taken people to surgery, but now they'll say, you know what? It would be kind of morbid. Why don't you think about doing that? And if we get a good response, then we can maybe think about surgery. Well, but when push comes to shove, a patient starts on pexidartinib, they start on vimseltinib, they get a good response, they're not having symptoms, they have half the tumor left. It's much back to what we talked about before. Well, what's the compelling reason to take out the rest? And so even in a setting where there might have been the intention to downstage, if you will, or make the tumor smaller and then do surgery, when you could get right down to it, they get the tumor smaller, they're asymptomatic, and it's like, well, why are we going to do the surgery? So I think sometimes there's the intent to do that, but I think the follow through with the surgery is probably a little bit lower than what was initially planned.
And actually, there was a clinical trial that was attempted to be started at some of the big cancer centers, literally for exactly what you're saying. And patients who went on therapy first, they dropped out of having surgery because they felt better. So I think that data will come. It'll just come much slower because I think once people are out of pain, they're not in a rush to be, cut into.
Right.
So, a last question regarding dosing. And so, have you had patients that start on, like, say, Pexi or vimseltinib, and they start at a lower dose instead of starting at the approved, top line dose and then working downward when they have side effects?
Yeah, that's I actually have done both. Um, and again, it's back to sort of knowing the patient and learning what you can about what's important to them. There are patients who you can get a hunch that if they develop a side effect that they're concerned about, they're going to bail. And I'm more likely to ramp up on those patients than go down. There are patients that if they don't see a quick response, they're not going to stick around for more. And I'm more likely to start at a higher dose, right? So a lot of it ends up being trying to get the drug into people in a meaningful way. And so most people I start at full dose unless there's a particular problem that would lead me not to. And mostly it's people who come in and they're really, really paranoid about developing a particular side effect, and we're trying to minimize that.
Oh, I was muted. Since you are the, Global Oncology Partnership person, I wanted to ask you about access and getting these drugs to other countries. Do you know of any efforts for Latin America and some of the countries that are untouched typically?
Yeah, I mean, it's an incredibly important question. I mean, I think that companies, part of it is companies and their sort of willingness to delve into other markets. Part of it is the countries themselves and their requirements to have trials that have had their population participate in those trials. And so it becomes a fairly complex issue. There ends up being issues with cost in a lot of countries rather as well. So I can't necessarily speak directly for the companies in terms of what their marketing or development plans are, but it is a significant gap that we do end up with a lot of us and them in terms of what we have access to and what other countries do. And we can try to continue to advocate for more broad approvals in other countries, but I think it's going to take a little bit of cooperation on both sides. Countries can't necessarily say, well, if our patient population didn't participate, then we're not going to accept the data. And then companies have to be a little bit more willing to sort of, get involved in countries that they may not have previously to provide access. So I think it's absolutely something that needs more attention.
Thank you. Thank you so much. And for advocacy efforts, we are working to try and get every country an option. So we'll continue with that and partner with amazing clinicians like Dale Shepard to do it. And so thank you so much for your time and all you do for patients.
All right. Well, thank you for all you do. I appreciate you putting this together and letting me participate.
Thank you so much. And you're getting claps. Have a good evening, everybody.
All right. Take care, everyone.